Okay, maybe we can start now. I'm Randolph Wong. I'm the director of the media strategy of the Vessel Plus. At the same time, I'm a cardiothoracic surgeon from the Chinese University of Hong Kong. So today we're very happy to have Professor Dr. Sunil V with us. He's a director of interventional cardiology in the NYU Langone Hospital. So without further delay, let's go to the first question. Could you discuss the progress in mechanical circulatory support for treating cardiogenic shock? I know you have done a lot of work in cardiogenic shock.
Thank you for that question. It's a very timely one, obviously, in the current environment where there's a tremendous amount of focus on shock, and particularly how to treat shock. I think, early on, there were really no other options except for vasopressors and inotropes, which have really been unsatisfactory in terms of their clinical outcomes. And it's pretty clear that there is a situation in shock where the heart needs to be supported and blood needs to be able to get to the vital organs. The first device, of course, was the intra-aortic balloon pump, which is a relatively low-profile device. It doesn't provide a lot of ventricular support. It does provide some, largely the Venturi effect of the balloon deflating. There's some increase in coronary flow. Randomized trials, unfortunately, have not shown that the intra-aortic balloon pump is beneficial in patients with shock. So there's a need for other mechanical support devices. I think the three other that are currently available are the Impella family of devices, the Tandem Heart, and ECMO. Randomized trials of these devices are very, very challenging to do because, first of all, there's oftentimes a lack of equipoise on the part of physicians to randomize these patients. They're very sick. The second is that the patients who do get randomized sometimes are ones who either may not benefit at all from a mechanical circulatory device because they're so far on the end of the spectrum of shock that they're likely to have a mortal outcome regardless of what the strategy is, or they probably didn't need the device in the first place, and they probably would have done well without the device. So it's a very challenging situation. Right now, I think that the most exciting data that have come out recently are the Danger Shock trial, which was done in Denmark and Germany with the Impella family of devices, largely the CP device. I think it was 99% use of the Impella CP. This trial did take a decade to enroll patients, so it's a very, very long, protracted process, very highly selected patients. But in that trial, the use of the Impella device compared with no use of the Impella device did result in a reduction in mortality at 30 days. So that's very exciting. It was counterbalanced by an increase in the risk of complications like severe bleeding, limb ischemia, et cetera. So I think that there's been a tremendous evolution in the use of mechanical support devices, but we have a lot more work to do in terms of deciding which patients are the right patients for mechanical support and how do we deal with the complications of these devices so that patients can have a good outcome.
It's a very comprehensive answer. Actually, I'm going to follow up through. In your own opinion, what strategy do you believe in your hand, in your center, are essential to improve patient with cardiogenic shock? In your hands, yeah.
It's a great question. And I think we are slowly getting to standardized protocols or standardized approaches to deal with these patients. And of course, these approaches need to be tested and supported. In our center, we do have a multidisciplinary shock team. So we have a single call that goes to cardiac surgeons, critical care physicians, interventional cardiologists, and heart failure specialists. Oftentimes, it's not to decide the treatment strategy for the patient that's currently there, but really to inform the group of what treatment strategy the interventional cardiologist has chosen. So, for example, if we have a patient that comes in shock, we require that all these patients get a right heart cath. So to determine hemodynamics. The choice of the mechanical circulatory support device is often left to the interventional cardiologist. But as soon as that support device is chosen, the shock team is, quote, activated, so everyone knows. And then there's a very, very quick review of what the current hemodynamics are, what the hemodynamics were, and then there's a collective decision that's made about whether that device needs to be escalated. So, for example, the balloon pump is placed, but the cardiac index is still below 2, the patient is not oxygenating well, the lactate is still high. We will escalate to an Impella device before the patient leaves the cath lab. So I think that's really the key. It's early identification, it's assessment of the hemodynamics, and then it's a multidisciplinary decision around what to do with mechanical circulatory support and sort of a continuous assessment of what that patient's clinical status is.
Well, I think that sounds like a very promising approach, and I'm really looking forward to, the study that to show the efficacy of such approach. Can you introduce your research on the radio access intervention? That's switched topic a little bit.
Sure. I got interested in radial approach really, gosh, probably in about 2004, 2005. And that was largely because before that, when I was in training in cardiology fellowship, I was very interested in antithrombotic therapy for acute coronary syndrome and non-ST segment elevation MI and STEMI. And I was really interested in the safety of those antithrombotic agents. We were studying a lot of different agents, a lot of different targets in the coagulation cascade, but the risk of all of those agents was an increased risk of bleeding. So we were trying to figure out how do we maintain the ischemic benefit of these potent antithrombotic agents and counterbalance the increase in bleeding risk. And one thing that emerged, particularly because all of these patients were going to the cath lab and getting invasive procedures, was that a vascular access site strategy could reduce that bleeding risk from switching to the femoral to the radial. We did a series of observational analyses that showed that there was an association between radial access and a reduction in bleeding. That was followed up by several randomized trials that we participated in, we led, showing, again, proving that radial approach compared with femoral approach reduces bleeding risk. And then some of the trials in ST segment elevation MI showed that not only does it reduce bleeding risk, but it reduces mortality. So then, based on that body of literature, I think there's been a dramatic increase in the adoption of radial access. We are, in the United States, lagged behind Southeast Asia. Southeast Asia had adopted radial access much earlier. In the US, when we first studied this in 2008, it was about 1% of all the procedures in the US. We currently have an analysis that's been presented, but is currently under review. And it looks like the rate of radial approach in the US is north of 70% now. So there's been a dramatic adoption. And the guidelines have embraced it. So the guidelines now give radial approach a class 1 recommendation in both patients with stable angina and those with acute coronary syndrome undergoing PCI.
Yeah, I think to echo with your comment, and in fact, in our hospital, in the principal hospital in Hong Kong, we do predominantly use the radial approach. And I think thanks to a lot of evidence that you and your co-worker have provided us, and I think that's proven to be a very safe and sound approach, especially I think for day case as well. And the patient can mobilize quite early on, right?
Yeah, and I think the challenge with that now, of course, is when we interact with our surgical colleagues like yourself, is how do we preserve that radial artery patency and minimize radial artery injury so that you can use that as a graft if needed. You know, there's a very recent publication a couple of weeks ago in Circulation Cardiovascular Interventions looking at the fate of radial grafts that have been instrumented compared with radial grafts that had not been instrumented. It turns out there's no difference. Now, the study has some limitations and so forth, but it does suggest with contemporary techniques to maintain radial artery patency after cardiac catheterization, that those grafts, in fact, do have longevity. So that's a very reassuring kind of finding.
Definitely. So as a leader in intervention cardiology, what changes or trend that you think is particularly exciting that you are facing and you think it is very promising?
Yeah, so I think, you know, the great thing about interventional cardiology is it's a little bit like cardiac surgery, right? When you say cardiac surgery, there's so many dimensions of cardiac surgery, so many different procedures. Same thing with interventional cardiology. You know, it used to just be focused on coronary, but now we're talking about peripheral disease, we're talking about valves. There's a lot of exciting things going on in all of those areas. So coronary disease is obviously a fairly mature area. Coronary intervention is fairly mature. So now I think it's really about implementation of evidence-based strategies. How do we make sure that we continue to proliferate radial approach? How do we proliferate the use of ultrasound for vascular access to reduce complications? How do we have the recovery process be more efficient for patients? So how do we get patients out of the hospital faster and safer? The use of intracoronary imaging now is rapidly increasing. That increases the confidence in our results and has long-term durability. So integrating all of those things into a patient-centered approach to make the patient experience better, I think, is the next very exciting frontier in coronary intervention. For peripheral intervention, you know, we still struggle with recurrence rates and restenosis. And so strategies to reduce the risk of restenosis and improve long-term patency and reduce claudication and critical limb ischemia are, you know, really exciting. Lots of new devices, lots of new strategies. Drug-coated balloons, for example, are very exciting in that area as well as in the coronaries. But the real excitement is really in valve disease. And I think you probably work very closely with your own interventional colleagues in the valve space. So, you know, new devices for mitral, for tricuspid are really going to be, I think, the future of how we approach these things. And interventional cardiologists partnering with our electrophysiology colleagues and surgeons to think about how do we deal with arrhythmias and stroke risk and left atrial appendage occlusion. So this is a really, really dynamic field. And every day I wake up and read something in the journals that excites me about what's coming down the line.
I absolutely agree with you. I think being in the field of cardiovascular medicine or intervention has been quite exciting in the last decade. I think I fully agree with all the development that you just mentioned. I think we are really riding on the right track of this kind of vast development. As the past president of the Society of Cardiovascular Angiography and Intervention, what motivated you to, take these positions? And can you share a bit of this with us?
Sure. I think, I feel an obligation to give back to the profession. I think, I can't imagine doing anything else except being a cardiologist or an interventional cardiologist. And, as a group, I think we have to advocate for patients and we have to advocate for ourselves. And the best way to do that is through professional societies where we can have an influence on the direction that clinical care goes, the development of best practice guidelines and clinical practice guidelines that are evidence-based. And at least, I'm based in the United States. I think we really have to have some influence at the legislative level to make sure that the payment schemes, the reimbursement levels, regulations, and laws are really in favor of patient outcomes. And really, the best way to advocate for that is through the profession. Cardiologists are the ones who have to take the lead on that. So I was very interested in that. I got involved very early with the society. I chaired the quality committee for many years. And then really had an interest in participating at the leadership level and joined the executive committee and eventually became president. And during my presidential year, I think SCAI was able to accomplish a lot. We were able to pass legislation to help support the use of physiology and intracoronary imaging in ambulatory surgery centers. We instituted a match process for fellowship training that made it much more fair and equitable for trainees. We were able to release several guidelines that helped to guide clinical practice. And our journal, the Journal of SCAI, really matured during my presidential year. So it's really been an exciting process to participate at that level. The society is an international society. So to anyone who's listening, I encourage all of you to join SCAI, whether you're based in the United States or not, and you can really have a leading voice in the direction of the profession.
It's really insightful, and I really admire your, leadership. I think these kind of leadership is very important to lead a society, no matter it's cardiologist or cardiothoracic surgeon. So to follow through, what accomplishment that you are most proud of during your tenure so far?
Yeah, wow, thank you. I should mention that the SCAI allows for cardiac surgeons and structural imaging cardiologists to join. So I just want to make sure that we don't think of SCAI as just an interventional cardiology society. It's really a multidisciplinary society. I think the thing that I'm probably most proud of is the team effort that it took to institute a matching process for cardiology fellowship. And the reason I'm proud of that is that, at the end of the day, all of us who are cardiologists or cardiac surgeons or anyone who's even a physician, we're only in our profession for a brief period of time. If we're lucky, we get to practice 30 years. And we have a tremendous impact on patients. But what our legacy really is for our trainees. It's the next generation. That's what our legacy is. And I think that having this fellowship match process makes it fair for trainees and makes a much better process for them to be able to train in interventional cardiology. And that's really going to, I think, have a lasting effect for trainees for generations to come. So that's really what I'm most proud of. I mean, I certainly can't take credit for it. It was really a team effort. Doug Drachman and Don Abbott, I'd be remiss if I didn't mention their leadership in this process. And of course, all the SCAI staff members that worked hard to make this happen. So that's something that I think I'm very, very proud of. And I think it's something that's important for the next generation of interventional cardiologists.
Talking about legacy, so I believe you agree with me that the mentorship plays a vital role in professional development. How have your former mentors influenced your career in intervention cardiology? Do you want to mention a few?
I do, actually, and I think this is such an important question. And I've been very, very lucky in my career to have great career mentors. I'd like to point out two of them. Bob Harrington, who was, has been a mentor to me and is still a mentor to me. He's currently the dean at Cornell Medical Center, and I worked with him very closely when I was at Duke. And the other person is a physician named Ken Morris, who was my chief of cardiology at the VA hospital. Ken Morris was my clinical mentor. If I ever had a clinical question about a patient, I was able to go to him. And he instilled in me something very, very important and something that I ask myself even now when I treat patients. And that fundamental question is, what is the goal of therapy? What is it that you're trying to accomplish when you treat this patient? And it may not necessarily be to prolong life for every patient. That patient may say, look, my goal is to be free of angina, or I want to be able to go to my daughter's wedding, not have be short of breath, or not, So thinking about the goal of therapy and what it means for the patient is the way I sort of approach patients, and that really was instilled in me by Ken Morris. For Bob Harrington, who's been my research mentor and sort of my life mentor, is really to focus on what's important. And what's important is not, an egocentric approach to scientific investigation or clinical research. It's really about, the importance of the scientific question. And what is the hypothesis that you're trying to prove? Even in clinical research, we're doing hypothesis testing. And also to think about, what is it outside of medicine that's important? Family is important. Friends are important. And it's making sure that you prioritize those things in the context of your overall career that I think makes for the appropriate work-life balance. And I still call on both of these mentors when I have questions, when I have career issues. And I think, that's what I've tried to do with the people that I've mentored, is to realize that our obligation is not just to our patients and our profession, but it's also to the next generation that's coming behind us.
Absolutely. I think I learned a couple of good points here. So turning to the other way around, so what advice would you give to your young, aspiring, booming cardiologists? Will you just follow the two mentors that we just mentioned, or you have any additional comments?
Yeah, I do actually, and I think the advice that I would give people who are in training, whether they are a cardiac surgeon, an internist, a cardiologist, if you're a physician and you're in training, I think it's important to think about how lucky we are. Yeah. This is an amazing profession to be a physician. People put their faith in you when they're very, very sick. You are responsible for making them feel better, making their life better, making them live longer. That is a very privileged position. So while we all get involved in our day-to-day lives and the frustrations of research or clinical care or maybe the hospital protocols, never forget when you're going home at the end of the day how lucky you are to have that job. And I think that's really the advice that I would give people, because that's what helps to motivate people to get up in the morning and do it all over again, is to realize how lucky they are. You're in a very, very select group of patients. It's difficult to become a physician. It's the tests that you have to go through. The training is very challenging. And so if you've emerged at the end of it and you're a physician that's able to take care of patients, you are incredibly lucky to do that.
Yeah, I actually can't agree with you more because I have the same feeling that we are the privileged group that are able to gain trust from our patient. Suggestion would you give to promote the development of Vessel Plus, this journal?
Well, I want to congratulate Vessel Plus on doing such a great job. I think that, focus issues are really important. I think those are important for practicing clinicians to be able to have a compendium of clinical research and review articles that are focused on one particular topic, particularly if it's a contemporary topic. There were some great examples that were shown earlier. I think those are really, really important. I think having cutting edge science and making sure that you're keeping up with the trends, and then very thoughtful editorials about how to take those clinical research results and put them into a clinical context are also very, very important. And it's very obvious that Vessel Plus is growing rapidly. And again, congratulations to the editors for doing such a great job.
So, final question. What do you consider be the key factor in a very successful establishment of building an academic journal? Is it the factor that you already mentioned, or any additional points?
Yeah, it's a very, very crowded space now. There are multiple avenues for people to publish, some of which don't have the same level of rigor, perhaps, that Vessel Plus does or some of the other journals do. And that's challenging because, I think the key is to focus on the mission. The mission is to publish good science. And as long as you keep your focus on that mission, the journal will be very, very successful. It's easy to get tempted to say, we should try and do some things that are very trendy that other journals are trying to do. But as long as you're focused on the science, everything else falls into place. And I think, keeping a laser focus on that mission is very, very important.